in response is going to be Professor Patricia Davidson. So Professor Davidson served as the Vice Chancellor of the University of Wollongong and President, and was also prior to that Dean of the Johns Hopkins School of Nursing in Baltimore in the United States. Trisha's an internationally recognised leader in nursing, health and medical science, but also has a particular focus on person-centred care, a theme that we'll be talking about a lot today, in terms of the delivery and improvement of the lives of people who have and experience complex and chronic conditions. So Professor Davidson's currently Vice-Chancellor's Fellow at UNSW and Co-Director of the International Centre for Future Health Systems. And Trish will be providing us with an overview of the Community Health Navigator research and development. And over to you. Thanks very much.
Thanks so much, Ben, for that warm and generous introduction. Thank you. Welcome everybody here today to this forum, and I just really wanted to acknowledge Mark and Liz Harris, who've had the vision for this work over many years. And I thought just over the next couple of minutes, I'll tell you a little bit about the centre. Now, this is my second day on the job, so no tough questions for me, but I have over the last month been sort of immersed in details. And I'm just also going to provide a bit of context today and some of my personal reflections. So I would also like to acknowledge country. Thank you to Arnie Donna for the warm and generous remarks, and recognise any First Nations people here today, and also acknowledge that we are on unceded lands. Also, I give you greetings from Professor Michael Kidd, who is the founding director of this International Centre for Future Health Systems, who is now day 2 as the Chief Medical Officer for Australia. So hopefully, you know, we can feed many of the results back to him from the day. He's in the driving seat, and see how we can really move this agenda along. A little bit about the centre. One of the really exciting aspects of this centre is that it recognises the multidimensional aspects of health. And so this is a pan-university institute with representations, particularly in the postdoctoral fellows, some of whom are here today. Do you want to put your hands up? There they are. Great, you could talk to them at lunch. Who recognise that, you know, the complex issues that Susan outlined in her presentation are not going to be solved by any one profession. And particularly if we're going to tackle social determinants of health, we need to sort of break down silos and boundaries. You've been really inundated with nurses today. I'm also still a registered nurse. I was in the pandemic for Baltimore, and I was just going to reassure Susan that those skills come back pretty quickly in emergencies, because that's in Baltimore in those days, it was all hands on deck. But so the centre represents some really interesting opportunities, particularly in the context of community health navigators. When we look at the intersection of healthcare services and social services, which is really, I think, one of the keys to moving us forward. We know that housing is such a powerful determinant of health and well-being, education, but if we look at the way government policy, our universities are structured, are often in silos. So the aims of the centre are really to engage in research, policy and advocacy across these key pillars, from equity through to pandemic planning. And I'm so glad that there is still a focus on the pandemic, because there are so many lessons learned on health systems in crises from the pandemic. Some people would like to think it never happened, but it did happen, and it exposed many of the frailties in our system. So across each of these pillars, we are trying to tackle some of these complex health issues. And the theme of community health navigators resonates across all of these themes, from primary healthcare through to healthcare workforce, which is a critical issue and will be a lot of discussion and debate, but also how we care for priority populations. And even getting that nomenclature right is very challenging. You would have seen the recent editorial in the MJA about people pushing back around the terms culturally and linguistically diverse. So, I think because it's sort of naming and othering, particularly in a diverse and culturally pluralistic society such as Australia. So I think there's such a lot of work that we have to do. And I also want to echo the Secretary's words in that we are living in very concerning times. The erosion of democracy, the naming, blaming and vilification of specific populations, the rise of nationalism and populism, these are the things that concern me each and every day. And so I think together we can collectively work to address this. And it has to be about community being the heart of care. So I'm just going to quickly set the scene because hopefully there's some people here today that have come to learn about community health navigators, but I also acknowledge there are experts in this room and I don't want to I tell experts what is happening, but I think it's important we set the scene. But community health navigators are trained individuals, often from the communities they serve. They help us navigate these very complex health and social care services. And in particular, they are effective in addressing barriers to care. And there's a part of the, if you like, not confusion, but I think the nomenclature and the language can be something that is limiting advancing the science. So I think that would be really useful to think about today. And, patient navigators, lay health workers, community health workers, all of these terms are perhaps used synonymously. And as a nurse, can I say that has not served nursing well? Because a nurse could be someone who's done a 6-week course at TAFE and is working in a facility, through to an advanced practice nurse inserting central lines or delivering anaesthesia. So I think getting the nomenclature right, the scope of practice, these are really critical issues for the field. And what do? I think Susan very eloquently identified this. They help in navigation. They provide important access for healthcare workers, for communities. And if we look at international experiences, and I know Professor Harris and his group have led a lot of the reviews in this space, but if you look at around the world, there's a lot of lessons learned in community health navigation. I had the honour and privilege of working at Mount Druitt Aboriginal Medical Service for nearly a decade and as a 1 day a week, and learnt so much about Aboriginal health workers, and we know they play such a critical role in, and this is a really interesting model to develop and evolve. I'm going to tell you a little bit about my time of living in the United States in subsequent slides, but particularly in the United States, they're pretty well embraced across many healthcare systems. Increasingly, they're being used in acute care, and interestingly, just in the recent report on the funding in New South Wales, it was recommended by Commissioner Beazley that healthcare workers be used for people with individuals with intellectual disability. So there's a wide adoption of the notion of the community health navigator across a range of areas. And of course, in global health, community health workers are sort of the bedrock of most health interventions. And even if you think back to the Ebola outbreak, it wasn't until the WHO and other agencies really started embracing community health workers was there any action on addressing Ebola. So we know these people are critically important, but I think today there's going to be a lot of discussion about how we meaningfully embed them structurally in our healthcare systems. So I'm just going to tell you a little bit about my time in Baltimore. Baltimore is an amazing place. It's where Johns Hopkins is. People often, when they think about Baltimore, think of The Wire. And yes, it's true. The Wire is true. That's what life is like in Baltimore, particularly for African Americans. Not if you're white and privileged, but for African Americans, there's huge structural issues of racism and also generations of trauma that impact health and well-being. Baltimore has kind of one of the highest murder rates in the United States. People will say to me, "Are you scared?" And I said, "No, because I'm white. I can walk down the street and for the most part I'll be safe." But for young people, particularly young Black men, it's a huge area of vulnerability. So community health workers, community health navigators really were embedded across the whole of the Johns Hopkins health system. And this is a photo here, and I put it here because there was a whole movement when I was there at the legislature, to kind of, if you like, formalise this role and function. Because there's a lot of fragility in that role. When you're often seen as the bridge or the add-on, when times get tough and finances are precarious, you're often the first to go. And also it's about standardising the scope of practice. And so there's been a lot of work through the Maryland legislature to advance the health worker role. Why is this so important? And I think living in Baltimore, I've never been so, impressed by the importance of social determinants of health. In a city like Sydney, it can sometimes be out of sight, out of mind. But as you can just see, just with a distance of 8 kilometres, there's just substantial, decades of difference in life expectancy and many other social indicators. And often then, particularly where you have world-leading health systems in that area, such as Johns Hopkins, University of Maryland, amazing healthcare facilities, why are the health outcomes like that? I can also give you some reflections about my views of how this will work. One of the first things that I did when so the School of Nursing had community health workers as part of a lot of our functional units. So the School of Nursing would run community clinics where community health workers, navigators were a big part of it, as well as we had a school clinic. But one of the things which was a little bit controversial, I closed down one of the nurse-led clinics, which was literally like 1 block away from Johns Hopkins. And people said, "Oh, how can you do this? How can you do this?" I said, because we need to navigate people into the system. Yes, sure, a nurse practitioner can see you, can prescribe, antihypertensives, but are we excluding renal artery stenosis? Are we doing any of those other more advanced therapies? And why should poor people have access to second-rate healthcare? And because most of the African American population in Baltimore actually would qualify for Medicaid, a lot of the work we did was navigating people into the health system. This is a study which again looked at, and this was actually funded by Medicare to really look at efficiencies. This was the J-CHIP program, a really big program at Johns Hopkins that integrated community health navigators into a broader model of care. So I guess my point is community health navigators are critically important, but the question is, how do we meaningfully embed them in the system? So, what are some of the challenges? And I hope we will be able to discuss many of these today. Where do these people sit? You can see so many logical places. Do they sit in a primary healthcare network? Do they sit in a healthcare system? I think wherever, and there's probably strengths and weaknesses, but what is the sustainable funding and program support? How do they integrate into healthcare teams? What is the level of training and credentialing? This is highly variable. How do healthcare workers across the ecosystem look at scope of practice? So nurses have to devolve more to community health workers and other categories of health workers. Similarly, allied health workers have to devolve some of their tasks, and similarly, physicians need to devolve some of their tasks. So the healthcare system for the future is not going to be the healthcare system that Susan and I started in. We have to look to the future. And I think the other thing, looking at the literature and looking at the many systematic reviews that have been done, where the recommendations for more rigorous research, and I think we need to refine nomenclature and also closely define the interventions. I think in my experience of working with community health workers, there's a range. From Aboriginal community health workers, where there is this embedded traditional knowledge and embedded in community, through to people who functionally navigate people, say through a cancer diagnosis, but don't necessarily have those cultural and social affiliations, through to faith-based or faith-placed interventions. And I spoke about this with Professor Harris. In Baltimore, many in the interventions embedded in the African American churches are much more than just having that intervention being conducted in a church. Many of them are integrated in spiritual knowledge and other factors. So I think if anybody has the appetite, it would be great to see an equator statement on criteria for reporting community health navigator trials, because each of these interventions is critically important. And as someone who has grown up doing nursing research, you know, one line in a paper, a nurse-led intervention model, tells you nothing about how you're going to replicate that model and how you're going to get similar outcomes. So today, from my perspective, I think there's a call to action. I think Susan Pearce has given us a really great outline of some of the challenges in the system. I think she's clearly identified that New South Wales Health should be a community health system. And I think for us, particularly researchers and clinicians and community members, it's up to us to provide some solutions, because anyone who has worked with government knows they don't want to hear the problems, they want to hear the solutions. So I think many community health navigator roles today have been incremental. They've helped for a while. There've been individual studies. As Norman Swan says, Australia is the land of the pilot project. How have we not moved from, seeing a difference to being embedded in systems? I think, as I mentioned, all of us, all healthcare workers, need to give a critical review of scope of practice. We need to think about what are the models for compensation and regulation, and also recognise that many of these people from these populations suffer similar issues to their fellow citizens. And this is clearly demonstrated in Aboriginal health workers, who often take on a huge amount of burden from their community, often at the extent of themselves. Commonly, community health workers, navigators are often women, and there's a whole feminisation of this nature and taking care of others other than yourself. And today, I think it's a great opportunity to think boldly and creatively, dream big, think about breaking down those silos and making a difference. And I think really, if we are going to have high quality, high value care, we have to walk the talk. We have to, so the evidence for the use of community health navigators has to be evidence-based. By definition, all healthcare needs to be interdisciplinary, and also how we meaningfully create person-centred models. I'll just leave you with this slide, because I like this, because it often thinks about, hard to reach populations, lack of engagement, is fundamentally how we want people to fit in our health systems. It never ceases to amaze me, even now, hospitals run from 9 to 5. If you want a wound specialist on Saturday afternoon, they're not available. How have we created this model, whereas many other industries have moved to 24-hour functional servicing? How are we going to think differently? So sometimes it's not always the fault. The reason doesn't lie with the individual, but the inflexibility and challenges of our health system. I always remember from my days back at the Aboriginal Medical Service in Mount Druitt, which is a nice thing to say about my cardiology colleagues, not one of them, when I called them, would not see a patient. But that's if I rang up. If the patient rang up, the first thing they said, yes, you've got an appointment, it's $250 on the day, and to them that's just like another window down. So that's just an example, I think, of how people are defined as being non-adherent, non-compliant, but of a system that is not necessarily supportive or enabling of their healthcare needs. So it's been my great honour and pleasure to be able to provide a few remarks here today.